Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Get CME for this episode by clicking on the CME link in the show notes. Today, we welcome back L. Joseph Parker. He's a research physician. Today's Kevin MD article is titled Navigating the New Minefield of ER Medical Practice. Joseph, welcome back to the show.
Thank you very much.
So let's go straight into today's article. For those who want to listen to Joseph's past episodes, go to kevinmd.com/podcast to search up his name. He's been on multiple times. He's a regular guest. What's this most recent article about?
In the state of Idaho, a law was passed making it illegal for any physician or anyone to perform an abortion except when the mother's life is not at risk, but basically when you're 100% sure she's going to die. And doctors had protested against that, and a federal court had blocked it, and then the appellate court went ahead and removed the block, saying that the protections were enough, and I don't think they are.
So in Idaho, if in the emergency department, tell us how that's affecting medical decision-making in the emergency department.
Idaho is already losing physicians over it. A specialist in this area, in the care for pregnant women, Dr. Lauren Miller, has already said that she's leaving the state. And she said, we have a death exception that is without any other guidelines. If I don't act fast enough to save your life, preventing you from getting septic, I could be liable for malpractice. But if I act too quickly and I'm not 100% certain that the patient is going to die from the complications she's sustaining, then I could be guilty of a felony. And that could be up to 5 years in prison. And she said, we don't know what that bar is, and no one wants to be the guinea pig first test case of that. So politicians passing vague laws about situations they don't understand is what I think is the problem.
So that gray area where the mother's life is at risk, is there no articulation in the law as to what that actually means?
No, just like the laws that say for legitimate medical purpose or in the usual practice of medicine, these are vague and undefined and will be filled in later as doctors are prosecuted and their careers destroyed and they lose their liberty. So you don't know what it means until someone goes away for it. And I would argue, having been an ER doctor, and I can tell you that the ER is a unique environment, having been both a United States Marine and in the ER is the closest thing to battlefield experience a civilian can get. I saw many more gunshots in the emergency room during gang wars than I saw in the military. And you have to make a command decision. You have to make a rapid, fast decision. To have someone Monday morning quarterback you and threaten to take away your liberty when you can't prove with 100% certainty that anyone's going to die. There's no patient who's still breathing that you can say with 100% certainty they're going to die until they die. Even people with metastatic glioblastoma brain tumors spontaneously remit. And they're putting the physician in an impossible situation. What it's going to make the doctors do is wait too late. The only safe thing to do is wait till they're almost dead and then try to save them. And that's going to kill a lot of women and babies.
Have cases like that actually come to fruition, to your knowledge?
They have. There is a doctor in Texas who is suing the state of Texas. And I think the mother's suing also because I think she had an ectopic pregnancy. And of course, as a physician, we know what that means immediately. An ectopic pregnancy cannot possibly survive. But because these state laws don't make exceptions for ectopic pregnancies, you've got to wait till the mother's about to die, which means that an ectopic pregnancy is outside the uterus, maybe in a fallopian tube. The physicians know that, nurses know that. As the fetus develops, it can rupture whatever it's contained in, and then there's intra-abdominal bleeding, and that can kill someone in 30 seconds. You've got just a fraction of amount of time. And this woman almost died because the doctor had to wait until the mother was almost dead. And that's the problem we're running into.
So you've worked in the emergency department setting, and it goes without saying how chaotic things can get there, and medical decisions need to be made sometimes on a split-second basis. So to be clear, state laws like the one that you're describing in Idaho, that is always in the back of an emergency physician's mind and potentially can influence their medical decision making.
Absolutely. We all don't want to be sued, but being sued is civil court, and you can defend yourself in civil court because all evidence must be shown to the defense. In criminal court, they're allowed to withhold evidence. Your chance of justice is much higher in civil court than it is in criminal. And doctors also know that when you are charged, your career is over, your life is effectively over. It doesn't matter what happens after that. Of course, it matters to you and to your family, but effectively, the charges themselves bring dramatic destruction to everything that you've built. And doctors are terrified of that.
What kind of guidance is being given to physicians in these states in terms of how to proceed and how to manage these gray area situations?
Extremely variable guidance. The politicians will say, as long as the doctor is acting in good faith, he's okay. But when does he get to prove that he's acting in good faith, or she? When they're in front of a jury. And by then it's already too late. Their career is already destroyed. It's years down the road. They haven't been able to practice. Everything they've built is gone. They're usually financially destitute, because it's not unusual for it to cost $1 million to defend a doctor against criminal charges. And we don't have insurance. That they have legal insurance for gun owners. They don't have legal insurance for physicians. And I think that's something that some of these legal insurance companies need to look into. Physicians need protection, not just from civil suit like our malpractice insurance, but we need protection from criminal charges. As a matter of fact, one of the states, and it might be Idaho, one of the malpractice insurers said, we are going to cover physicians for criminal charges for this purpose, for abortion specifically.
How commonplace is that, to your knowledge?
Extremely rare. That's the only state to do so. In the past, doctors were not usually charged unless they had been exceptionally negligent and mens rea, a guilty mind, unless they had criminal intent. But now they've gotten around that by arguing knew or should have known or willfully blind. So they can prosecute any doctor if he aborts the fetus to save the life of the mother. They can prosecute them and say he was willfully blind to the fact that she would have survived without having to do that procedure. And then you end up arguing to a lay jury medical issues that are so complicated that you and I, not being OBGYNs, probably would not be able to give a valid opinion on. I can give an ER doctor's opinion, but I can't give a valid opinion on when exactly, is the right second, and OBGYNs would not agree. The practice of medicine is not just a science, but an art, because every patient is individualistic. And before, prosecuting doctors who had clear criminal intent and restricting prosecutions to that protected us. But now, if someone in the state of Idaho, a prosecutor, wants to make their name known in the community, and especially in the community that's against abortions, all they have to do is prosecute a doctor. Win or lose, they're going to be that group's hero, and that can catapult them into a political career. And that's what we're going to see. We're going to see prosecutors with political ambitions prosecuting doctors for the purpose of getting their name out there.
And this law is causing not only emergency physicians, but obstetricians, gynecologists from leaving these states. Is that correct?
Absolutely. And it's already hard to find an OBGYN. I have many colleagues that are doing other areas of medicine now who had done their residency in OBGYN and went back and did something else, because they're saying, I'm not going to pay these malpractice premiums. I'm not going to be under this kind of scrutiny. You can deliver a baby and you can be sued 18 years later based on the child's grades. They can say, well, there must have been a anoxic injury, and they'll find an expert somewhere to agree, and you end up defending yourself in court. But civil court is very different than criminal. Criminal charges, you are accused of knowingly and willfully killing somebody or something, or committing a crime. And many, many doctors are being prosecuted who had no criminal intent. They just made a decision that a politician or federal agent doesn't agree with.
An obvious outcome, of course, is that patients are going to have a harder time finding care. Now, to your knowledge, has that happened yet in Idaho? Are you hearing stories where patients can't find an obstetrician gynecologist or even in the emergency department being short-staffed because of laws like this?
Absolutely. The high-risk patients, the ones with the preeclampsia and all of that, they're having extremely hard time finding anyone who will take care of them. Because who wants to be responsible for that? And another thing, the doctors willing to take the most severe cases, the sickest people, are going to have the most complications, and that will make them look like a bad doctor, right? So more of your patients are going to die. It's like the primary care doctors who accept oncology patients into their practice. Well, you're going to have a lot of patients dying, and that can be used against you. That the insurance companies have these AIs are now scanning databases, looking for these statistics, and they say, oh, look, 8 patients died within 30 days of seeing Dr. Johnson. It doesn't say those 8 patients had kidney failure, liver failure, cancer. It doesn't say that. It just throws your name up. And once you get scrutinized to a certain degree, a prosecutor will find a reason to convict you. And I have a videotape of one of them saying that. I have a videotape of a prosecutor saying, if we look at them for overprescribing and we can't prosecute them, then we'll try to get them for healthcare fraud or money laundering or something else. Now, he wasn't saying that to a group of doctors. He was saying it to a group of prosecutors.
Now, short of leaving the state, what kind of advice do you have for these physicians who want to stay in practice?
It's a very tough thing because you have to decide if you choose to stay in that state and you're an ER doctor, you have to think ahead of time. You better get a good relationship with a healthcare specialist, criminal defense attorney, and try to get some legal insurance if you can. And you better be ready and have thought this out ahead of time, because the battlefield decision, the command decision you make could completely destroy your life, even if you're acting in your, in the best interest. So what hospitals need to do is have a non-prescribing, non-physician specialist who looks these things over, is trained in it, or is a physician who's not actively practicing, who can come in and say, yes, it's time. And then it's not that individual doctor making that decision. If you've got backup, if you've got someone going into court that they can't charge with a crime, willing to stand up for you and say, yes, I told them now was the time and here's why. More of a scientific point of view than the medical doctor. Then it's much harder to convict someone if others will stand up and speak out for them.
Now, to your knowledge, does that happen? Having some type of non-clinician, legally sound backup for physicians with these cases, does that happen?
Yes, you will see that large pain practices have what's called an opiate medication manager. And this is usually a non-MD position. Usually it's a master's degree or something. And their job is to basically addiction and diversion avoidance. And they look for cues that the doctors didn't see, and they're specially trained to know what these are and to look for them from that perspective. The doctor's always looking from, how can I help you? Not, are you trying to deceive me? But again, you have to be able to afford that big, you have to be a big practice to be able to afford that specialist. But that's what hospitals will need to have on hand. It won't be a bad idea if they also have maybe an MLS, a Master of Legal Studies in Healthcare, and Master of Legal Science in Healthcare, it's sometimes called, so that they've got some legal knowledge also.
What other states have laws similar to the one you're describing in Idaho?
Almost half the states now. I think there's 24 or 25 states that now have laws that are, prohibit abortion. Most have the exception of of saving the life of the mother. Even those that don't, EMTALA, which is a federal law regulating treating people in emergency rooms, requires that you try to save the life of a person who comes in. You must stabilize them. And that was what this original lawsuit was under. The doctors sued and said, hey, this is violating the federal EMTALA law. You're telling me I can't stabilize this person. But, the Ninth Circuit said, well, the doctors have enough protection by arguing good faith. What they don't acknowledge is that when you are charged, the harm to you is irreparable. So there needs to be, I think there needs to be a federal law passed that you cannot prosecute a doctor for anything without criminal intent. You can always take civil action. If they're prescribing in a way you don't like, why don't you just take their opiate prescribing certificate, their DEA certificate? Then they can't prescribe anything controlled. They don't do that because that's a civil matter. And they would have a heck of a time defending their reasoning for doing that in civil court because they would have to open up all the records. So they go criminal. And I think Idaho, it is only a matter of time until a doctor is charged with this. And the first prosecutor to do so will be the darling of the group that doesn't want to see these procedures done under any circumstances.
We're talking to L. Joseph Parker. He's a research physician. Today's Kevin MD article is titled Navigating the New Minefield of ER Medical Practice. Joseph, let's end with some of your take-home messages to the Kevin MD audience.
I would say if you are in one of those states and you're an ER doctor, research what the laws in the state are. Think ahead of time of what you're going to do in that situation and have some backup. Speak to the hospital's legal department. Make sure you know how much support you're going to get, because I guarantee you it will be a lot less than you expect.
Joseph, once again, thank you for coming back on the show and sharing your perspective and insight.
Thank you, sir.